The next segment we have is our top abstract nominees that were nominated for the scientific committee. We recognize not just the quality of these write-ups and the work they're doing, but also the relevance for this conference. And so we have the top number one abstract from Mr. Devy Frederick representing CariGenetics from Bermuda. And we also have Dr. Angela Zambrano, number two top ranked abstract, who will be presenting afterwards, and we'll take questions individually. So these are 15-minute presentations with 5 minutes of Q&A each. Right, so Devy Frederick is a biochemist, genomic researcher, and entrepreneur advancing cancer genomics and precision health in the Caribbean. With a foundation in biochemistry, he transitioned into genomics to address a critical gap, the underrepresentation of geographically isolated and ancestrally diverse populations in cancer research and risk prediction models. He holds an MSc in genomics medicine from Imperial College London, where his research evaluated the transferability of commercial polygenic risk scores for prostate cancer in the Caribbean populations. His work contributes to the broader effort to ensure that emerging precision oncology tools are equitable, representative, and clinically meaningful beyond the populations in which they were originally developed. Through initiatives such as Caribbean Genome Project and regional cancer genomics collaborations, Devy works closely with clinicians, laboratories, and policymakers to translate genomic insights into real-world healthcare systems. His mission to build sustainable genomic infrastructure in small island states and positions the Caribbean as an active contributor to global cancer research rather than a passive recipient of externally generated data. So we're very happy now here to welcome Mr. Frederick.
Yeah, thank you for having me. Just want to confirm that you could, one, see my screen, and two, you could hear me properly.
Yeah, we can see your screen and hear properly. Your video is off, however.
Oh, my video is on, but it's fine. So thank you everyone for having me again, and I'm pleased to be selected as one of the top abstracts. This presentation is really on my dissertation I did at Imperial College in London. When we were assigned to do a 3-month project, the first thing that came to mind was I need to do something that is relevant to the Caribbean. Yes, I'm in the UK, but I want to do something that I want to analyze or do some interpretation of our data. Now, doing that is difficult for a genomic medicine program when you think that the Caribbean has limited sequencing capacity. But thankfully, with my work with CariGenetics, I was able to get access to some data. So it is preliminary data, but it was still something that I could do and something tangible and see how that could impact our population within the Caribbean. So this is what, just giving a background of what my talk was. It was mainly around a prostate cancer study, and we will dive into it. So the whole goal of genomics is to ensure that we're able to achieve precision medicine. And what that means is we're able to have a personalized approach and move away from the one size fits all model. And Dr. King would have um, mentioned some of this earlier this morning, but there is this idea that because people from the Caribbean are of African descent, that whatever research that is done in Africa or whatever research that is done on African Americans is easily transferable to us. And that is not the case. And I did not include the slide, but we have a lovely slide that describes the Caribbean as a melting pot of different ethnicities, not only African, but there is also Indian, European, Chinese, everyone who's come together, the indigenous people, for example, and that is what makes us unique. So it is very important that we are able to do some analysis on our data to find out why there are so many challenges within the region. And global research is not very representative of the globe, to say it that way. Over 85% of the diverse population is not included when it comes to drug safety or efficacy. And to make it even more specific, most of the research done was on males of European descent. And that data is what is used to make decisions for everyone across the world. And that is a problem because, like I said, it is not necessarily transferable. And that is where we need to start thinking of how can we now generate data for ourselves and what would that data look like? And this is the whole goal of what we're doing at CariGenetics and trying to launch what we call the Caribbean Genome Program, which is where we would sequence 250,000 people from the Caribbean. That way we have tangible data and we could start looking into all the challenges that exist. And this slide just shows what just the number of problems we have in this part of the world. And I know this conference is really focused on cancer. So we're the leading region for both breast cancer and prostate cancer. And my next slide will show that. But we also have issues when it comes to cardiovascular conditions. We have a lot of metabolomic conditions when it comes to diabetes and obesity. Chronic kidney disease, Dr. King just showed the statistics we've found when it comes to the gene APOL1 and the number of carriers of either G1 or G2 to the point where the lead for APOL1 globally, he said like this is a national problem because our rates are almost 2 times that of Africa. And you could think of this as because the Caribbean is all these different islands and we're geographically isolated, it could be what we call a founder effect, where something that is seen to be rare on a global level might just be common because of our small nations being so isolated and there isn't much migration happening between the islands. But just to continue from chronic respiratory diseases, sickle cell disease, and even Alzheimer's. But today my talk is mainly on prostate cancer. And this slide shows that in the top 10 prostate cancer risk globally, six of the countries, sorry, are from the Caribbean. And we would have mentioned earlier today about the French Caribbean, but there are also Barbados, St. Lucia, where I'm from, Puerto Rico, and the Bahamas. And if you even look at the top 10 deaths for prostate cancer, 7 of the countries come from our region. Now, there are multiple factors that could play into this, right? It could be socioeconomic, it could be that the agriculture. I know that some studies were done on the agriculture, but maybe there's a deeper reason, and that is on the genetic side of things. And that is why, and there hasn't been much studies done when it comes to genetics in the Caribbean. There's only been one study done on the French Caribbean men, and this just shows that we need to do more. So for the CariGenetics study, the way I was able to get data for this project, the attempt was to get data for prostate cancer in Caribbean history. We recruited 3 groups. So we had the patient group. So these were individuals over the age of 18 who have been diagnosed with prostate cancer. There was a control group. So these individuals had no prostate cancer, but we also looked at a related group. So those are men, sorry, with no prostate cancer, but they had a first-degree relative with any form of cancer. So the goal was to recruit 50 men from each 3 of these groups, and to be eligible, you had to be over the age of 18. And we wanted to ensure that there is a Caribbean aspect of things. So each individual needed 4 Caribbean grandparents from the Caribbean. So you could be from any of the countries, but you needed 4 Caribbean grandparents. And the whole goal of this was early diagnosis. We wanted to find out if we could see any genetic differences for Caribbean men, and that would allow us to now do predictive screening and potentially early intervention. Now, just wanted to say that everyone who participated did give consent to this study. We ensured that we followed GDPR standards, and all data was stored in a trusted research environment. Because again, when you're dealing with genetic data, it's very sensitive. A lot of people are afraid of the data being leaked. So we ensured that everything is stored in our databases based in Bermuda. Nothing was stored in the cloud. And these are the 2 countries that we've launched this study in. So the first one is Bermuda. At the time, that is what my dissertation was on, because we only had access to Bermuda. But we recently completed St. Lucia last month. So we've recruited 160 men in Bermuda in under 6 months, and in St. Lucia, we've recruited 157 men in under 9 months. Now, what we found, so the monogenic risk for prostate cancer we found was less than expected. So when you look at, if you look at the global statistics, the expected rates of monogenic risk, meaning that there is one gene that is really involved in the development of the cancer, is thought to be 5 to 10%. In Bermuda, it was 2%. Now, when we compared that with a breast cancer study we did in Bermuda as well, it was 20%. So we just showed that the prostate cancer was not really monogenic. We only got one positive case in about 50 of the patients. And this just shows that this was the example, I believe it was a CHEK2 gene that gene affects DNA repair. So you could see the clear inheritance within the families, within that family, sorry. So there's a good link for that. But it started to beg the question, is prostate cancer in the Caribbean more polygenic? Now, polygenic, what that means is there is multiple genes involved in the development of the condition. And thankfully at CariGenetics, we have a test called a polygenic risk score. And what it does is it allows us to look at the risk, the inherited risk of an individual developing the condition. So it looks at hundreds of these multiple, what they call a single nucleotide polymorphisms, and we're able to give an individual a risk of are they of high risk for developing prostate cancer, are they low risk? So what we did was we ran this analysis on all the patients that we recruited. And just to give a summary of what the cohort looked like for this analysis, so we had 157 men that qualified. 48 of them were patients. 48 were from the related group. 61 were controls. The average age was around 66 for the patients, with the outlier. The range between, I think the youngest was around 38 and the oldest was up to 80. The average age for the related was 54, and the average age of the controls were 47. So you can see that the patients were a lot older. Most of these men were predominantly African ancestry, and there was a small European contribution as well. Just wanted to make note of that. And what we found was 3 in 5 patients were flagged as high risk. Now, that was a telling statistic. So these men were already diagnosed with prostate cancer. We ran a genetic test to find out what their risk would have been, and we identified 3 in 5, which is 60% of those of our cohort were flagged as high risk for prostate cancer. Now, that is a significant statistic because this is a test that you could do. Like this test looks at your inherited risk, so it doesn't change. You could do this test as early as 18 years old and realize that an individual is at risk for prostate cancer. Now, that doesn't mean that you're going to get the condition, obviously, but it is important to at least have that metric, and you could use that to monitor what your environment looks like. So you would maybe do PSAs more often to ensure that you catch it earlier. So this was very important statistic that we found. And my dissertation, what I looked at was, can we use a polygenic risk score to help with a population risk stratification? Can we use genetics to help us screen out our population, find those individuals who are of high risk, and then monitor them to see if we could catch the cancer earlier? And like Dr. King said, before it was thought that once you have cancer, that's the end of the day. But now with the technology that we have, we're able to treat prostate cancer much earlier. So current screening, you would look at your PSA.
Hold on, Devy. It was like we just lost you in the room.
Can you hear me?
Yeah, we can hear you now. Okay, go ahead.
We good? Okay. Cool. So current screening, you look at your PSA, so your prostate-specific antigen, you look at the age, you look at your family history, and clinicians would use this to say, okay, whether this individual is of high risk. And I'm pretty sure that is not even really done properly on a population-wide scale. I think in St. Lucia, we just launched universal health coverage, and anyone could go in to do a PSA. But it begs the question, can we now do a personalized screening and using PRS? And that could be on an economic side better because now we've already identified those of high risk. So we know that these people should get tested more frequently. But if you have low risk based on your genetics, maybe you don't get screening every year, maybe you get screening every 2 years. So that is what we looked at different models using logistic regression to plot different curves. So to explain this, I ran different models to see statistically, how could we predict if someone would get prostate cancer? And the models that performed the best was when I combined family history, the ethnicity of the individual, the polygenic risk score, and the age. So that gave me the biggest area under the curve, which was 0.854, sorry. But when I did that same analysis with, let's say, family history and ethnicity, family history and age, family history and like over 60, under 60, they did not perform as well compared to if I did it with all four of those variables. Now, the one limitation of our study was the PSA. We did not have the PSA result for every man that participated, and we also did not have the PSA at the time of diagnosis. So the PSA, you could see the dotted line. It gave us the weakest area under the curve. It was 0.5. But that just shows that the importance of collecting accurate data and trying to collect as much data as possible. But it was a limitation, of course. But the main takeaway was based on this, although it was a small cohort and we need more to make like a statistically to meaningful result, we need more data, but it just shows that the model that had the most variables with the PRS performed the best. And this was similar to a study done in Sweden. So this study done in Sweden in 2021, they did a similar approach. And if you could look here with the bar graphs, just looking at PSA alone, which is what most of our screening techniques regimens done in the Caribbean right now. If you look at PSA alone, they got an area under the curve of 0.638. When they did the PRS alone, they got 0.659. But when they did the polygenic risk score, looking at the genetics and the PSA, it got the highest area under the curve, which was 0.716. So this begs the question of whether we could add genetics as another layer into the screening programs that we're doing right now in the Caribbean. It allows us to now look at things from a personalized perspective and not fitting everyone under that one umbrella. And there are several limitations with PSA. I mean, it's not specific to prostate cancer. You could have prostatitis where you have inflammation of the prostate. So that also, PSA is also led to a lot of false positives. So these are different approaches that we could take in the Caribbean. So now into St. Lucia. So we've looked at Bermuda data. So we said, okay, we've completed the study in St. Lucia. Let's look at what the numbers are in St. Lucia. In St. Lucia, although it was not as high as Bermuda, we found that 1 in 3 patients were flagged as high risk for the same polygenic test. So it is not as high as 60%, but it's still 33%, which is again still significant. The other thing we noticed, the other trend, is that the monogenic rates was still low. It was 4% in St. Lucia. So again, it begs the question whether prostate cancer in the Caribbean, is it more polygenic? Should we try generating more data to see how significant this is on a statistical level? And that's why we're upcoming cohorts. So we are looking to do this in Grenada in partnership with St. George's University. We've already gotten ethical approval, just waiting for approval from the Ministry of Health, and also scaling on to Trinidad and Puerto Rico to try to generate data and doing similar analyses that could help with policy drafting. And for example, when you're trying to do universal health coverage, it would be important to now include genetics because, like I said, we're pushing for this whole personalized approach. So this is the test. Just wanted to show it. So it's called MyRisk score. It's just a cheek swab, and we send it over to our lab. You get the result in 3 to 4 weeks. And it's not only for cancers. We have a whole list of other diseases that we look at. So from coronary artery disease, celiac disease, chronic cancer, hypertension, stroke, type 1, type 2 diabetes. So these are all conditions that we look at from just that one test. And these are just some other statistics that we've found. I just wanted to show you that we've done testing in Bermuda, BVI, and Trinidad and Tobago. And you could see, like I've spoken about prostate cancer in Bermuda, how high it is. But the main point of this is to show that no island in the Caribbean is the same. And maybe looking at the genetics would help us understand why we are plagued with so many non-communicable diseases. It is easy to blame the socioeconomic factors, but maybe we should look deeper at the genetic factors involved. So that concludes my talk. I'm open to any questions. And thank you again for having me present on the study that I have done.
Right. Thank you very much, Devi. Wonderful presentation. And want to identify this previously. I would like to personally congratulate you on being the nominated the top abstract for this inaugural conference. I always want to really, I don't have the exact comments, but I know the scientific committee was very happy with what you produced and gave glowing reviews. So congratulations to you and a wonderful presentation.
Thank you.
Right, so I'm going to open up the room to a few questions and also online if there are any. So, Dr. Jonas, a lot of questions. Go ahead.
Frederick, great talk. I messaged Karika as well. I've met her in Trinidad. So I'm a urologist. So this is exactly what I'm passionate about. And I think polygenic risk scores are the future as a complement to finding cancer. So well done on your work. It couldn't be more timely. So a couple of questions, and I'm not trying to monopolize time, just interject, but it's all dollars and cents here. What's the cost of this being rolled out? What is the cost for a patient to have it, and would it be covered by insurances? Would it be covered under the government?
So it would cost about $250 US right now to do the test. Now we have been trying to speak with insurance to cover this, but they're not really, I don't think they're experienced with genetics. That's something new to them. And that's one thing. The second thing is a lot of countries don't have a non-discrimination act when it comes to genetics. So we would hate for someone to be deprived of insurance based on a result from a genetic test. So we have been speaking to government a lot. We have been advocating for policy to put in that act where you won't be discriminated because of your genetic result. Because again, yes, genetics is one thing, but there are multiple variables that could affect or contribute to you developing a disease. But we do think that having insurance cover this, or even, for example, countries like St. Lucia rolling out universal health coverage, if this test could be integrated into that, where they cover it or they subsidize it, then that could help more people take the test, because we do understand that the cost is a factor. The other thing we're trying to do is map out the Caribbean, because not all islands are the same when it comes to GDP. The prices I gave are mainly for Bermuda, which will have like a higher cost of living. So if we could have it where maybe St. Lucia, the smallest states, could get for a cheaper price, around 200 US, then that too could help.
In terms of, PSA, yeah, there are failings for it, but I would just probably go on record and say it's still the best screening test that we have currently, because it's low cost and widely available and easily accessible. And I've seen your chart, and I completely agree. It's not good enough. It needs to be coupled with other things. What's your view on MRI scans, in particularly with the Transform trial coming out in the UK? Just for the benefit of the audience, the Transform trial is looking at MRI scans as a potential screening modality in the UK.
I think, yeah, we could do MRIs as well, but if you're looking at for like a cost, it is expensive to do an MRI in St. Lucia. I know, because actually one of my family members just did one because their PSC was high and there was no inflammation there, so they needed to do an MRI. Again, with the Caribbean, most of the individuals are not insured, especially the men. You could speak to the urologist. Most men are not covered, don't have health insurance. So it becomes a cost if it's out of pocket. And a lot of the men, they won't do it. They would rather wait until they get symptoms. Unfortunately, when you get symptoms from prostate cancer, that means it's a bit too late. But that is just a difficulty we have in this part of the world. So yes, I am open to MRI, but again, the question begs, who covers it?
Yeah, it's very difficult, isn't it? And I last question. Um, what are the barriers to enrolling other islands? Your chart looked at the highest incidence of death, and Barbados was up there. Obviously, I'm wondering why they're not on the list, among others, of course. Is there any barriers, and what challenges have you faced?
I think the biggest barrier is buy-in. Um, I mean, doing a presentation, a lot of people are interested, but then when it comes to taking action and actually, launching the study, that is when it becomes difficult. You find that a lot of work has been done in St. Lucia and Bermuda. That is because I believe that they're more open to the research, and maybe because I'm a local from St. Lucia, they know the face. Maybe I'm not sure, but it's easier for us to propose a study there and have it ethically approved. So, for example, we're working with St. George's University for Grenada, and we got ethical approval pretty quickly. But I think it's been 2, 3 weeks. We're waiting to get approval from the Ministry of Health. So again, we can't really start that project in Grenada until we have that. So it's really important for us to try cover the whole Caribbean. Like I said, we're trying to work on the Caribbean Genome Program, which is where we sequence 250,000 people from the region. But in order for us to do that, we could get the funding. We would still need that introduction into those islands and for those making the decisions to understand the importance of this and allowing us to do that work and generating that data.
Yeah, you either need local champions or you need to expand your staff with someone from every island, like you
Yeah,
from St.
yeah.
Lucia, like Cargo from Bermuda. Well done, and I'll be in touch.
Thank you.
Okay, so we'll take one question online very quickly. I believe Linda Lubren hands was up, so go ahead when they unmute you.
Hi, good morning, everyone. So my name is Lindell, and I live in St. Lucia. I'm from Dominica, and I work with Dr. Ogist and Trisha Black on the Casidic study. And so thank you for that wonderful presentation. My question actually is, I think you may have just answered the question. You said that you had, I guess, a lot of positive, what do you call it? Results when you try to engage St. Lucians and people from Bermuda about the study. And
Yeah.
my question is, I I think you said also that men are historically more hesitant toward accessing medical care, and sometimes they wait when symptoms appear. So, what was the difference with this study that you were able to engage so many men? Um, and I know you said you're a local St. Lucian, so that may have helped. But is there anything that you feel was different about this particular study that the men stepped forward and that you were able to generate, collect data from them for your study?
So that fact of me being a face was, I don't think it contributed at all because I was in the UK doing most of the recruitment. My team was the one doing the consent interviews and stuff. But it was really surprising to me how open men from St. Lucia were for this study. It was one of my biggest concerns when Karika approached me and said we want to do a prostate cancer genomic study in St. Lucia. That has never been done before. I did not know what how the public would have accepted it. But we did a lot of work when it comes to education. So in St. Lucia, we speak English and we also speak a Creole. So we did a lot of material around that. We started showing real world statistics, Caribbean statistics. I think it also helped that we had some data from Bermuda because we could show, okay, this is what's happening in Bermuda. We want to see what's happening in St. Lucia. Are you willing to join? I also believe that through the partnership with Lab Services, Dr. King, they were doing free PSA testing already for, I think it's called the Lions Club. So we were able to get to get men from that. So those were men who were already checking on their health because they were getting their PSAs done often through the Lions Club initiative. So a lot of our men came from that. So these were men who were already health conscious. The other thing is for recruiting the patients, we work very closely with the urologist. So I think all the patients came from him. So the approach we took is, yes, you've already been diagnosed, but participating in this study could help people who have not been diagnosed, who have not gotten the condition yet. So they were really open to that kind of research. Again, it's the first in this area, but they were pretty accepting of it. So that's pretty good. I'm hoping that we could replicate it in the other islands as well.
Okay,
Thank you very
thank you
much.
so much. Thanks.
So unfortunately, that's the last question we have time for, but thank you again, Devy, for a wonderful presentation. And I hope to have a conversation if you're on a separate occasion.
No worries.
But,
Thanks for having me.
yep.